My name is Dr. Bo Remenyi. I'm a children heart specialist doctor from the Northern Territory.
Could you tell us the key issues that are emerging for you up there in the Northern Territory in your work?
In the Northern Territory and in many parts of rural and remote Australia, we're still seeing diseases of poverty. We're seeing children dying from a condition called rheumatic heart disease. On average, 2 young people per week die from rheumatic heart disease in Australia, and this is a condition that has been eliminated from Western societies.
What causes this? What is the problem? What are the underlying determinants that are giving rise to this?
So rheumatic heart disease is caused by repeated exposure to streptococcal infection of the skin and the throat, and the underlying determinants are housing. So we're looking at severe overcrowding in rural and remote Australia. We're looking at houses that are not maintained. We're looking at communities that are poorly educated about health hygiene, and we're looking at communities that have very minimal access to basic health care.
Could you tell me about the healthcare to do with this disease? Because you say that it can be detected, but in fact some sectors of our healthcare service aren't skilled to pick this up.
Exactly. So we see a lot of high turnover of staff in rural Australia, not just in the Territory, but also in Queensland and Western Australia. And when we're seeing GPs and nurses coming up from the southern states, they have very little knowledge about diseases of poverty, whether it's rheumatic heart disease or whether it's how to treat syphilis or trachoma or pussy ears.
Okay. And can you tell me what the solutions are? What do you see we need to do in Australia?
If you need to have a comprehensive solution, this is something that we can definitely do in Australia. It's really simple. We must address housing regardless what it costs. We have to reduce overcrowding. We have to make sure that we maintain houses. We have to make sure that taps are running, washing machines are available, and that the houses are the plumbing is maintained, the sewage system is working. Secondly, we have to make sure that we have a nationwide education campaign so that nurses know about these conditions, doctors know, but most importantly, communities and children know about the condition, how important it is to treat simple skin and throat infections because they're highly contagious. We have to increase our workforce. And the final thing that we need to do is the kids who already have rheumatic heart disease, we need to pick that up early by active case finding. We need to go out there and look for these kids to prevent the need for open heart surgery and death. These are really simple solutions, and yes, we need a vaccine to stop infections, but what we need today is we need action on the ground. We need investment directly into communities, and we need their leadership to come up with solutions on how to solve these issues. We need community-based solutions.
Now, you visit remote communities every week. Tell me about Maningrida, what's happening in Maningrida.
So Maningrida is a small community, about 2,500, 3,000 people, and the community has got behind this problem. They own the problem, they developed their own solution and acquired their own funding. The funding is small, but it's a significant amount of funding to move forward towards having additional nurses at school in relation to implementing health modules in primary education and education of the community, and also investing in active case finding to minimize the need for cardiac surgery. So what we need is comprehensive models. We need to be community-led, and the solutions are slightly different everywhere else, but this is really basic human rights.
But what have you found there yourself? You go out and test children yourself, you listen to their hearts. What have you found?
We found that for every known case of rheumatic heart disease, we find at least 1.5 new cases, and those kids who have rheumatic heart disease, majority of the cases are not detected by our existing primary healthcare systems. So our current primary healthcare system misses kids who need open heart surgery. And when we went out and checked 650 kids in the communities, we found 3 new kids who needed open heart surgery, but we found a total of 32 kids who needed monthly painful penicillin injections for a minimum of 10 years.
Why aren't they getting why isn't the primary health care givers picking this up?
We have a shortage of doctors, and we have a shortage of nurses, and we have a very high turnover of staff altogether, including Indigenous health workers. So what we really need to make sure that the people who come up as locums, they actually have skill sets in diseases of disadvantage.
And that's about actually being able to listen to the heart and detect.
That's exactly right. So doctors have the skills to listen to the heart, and most of them do it pretty poorly. But when we're looking at nurses, they don't even have training on how to listen to a child's heart. This is really, really important to make sure that we have a skilled workforce, which means kids actually need to be seen by doctors, or alternatively teaching remote nurses on how to auscultate children's hearts. Or, of course, the other option is just having a screening system where every kid has an echocardiogram every 12 months to see if they acquire the disease. But we shouldn't need those if we address housing, education, and access to healthcare.
Could you give me some reflections on the conference, Bo? You've met a lot of people here. How have you found it?
I found this the most amazing conference that I ever attended. Such a nice group of highly intellectual, passionate people who care so much for rural and remote Australia, and I think together we can really ensure that all Australians have equal access to basic healthcare and social infrastructure.